So I wanted to thank everyone for joining us today for what is our 16th annual Melanoma Education Symposium. I can remember when we had people flying in to hear data which was just this big, and now we've come to a place where we have a lot to present and everyone can be in their lovely homes. I wanted to thank everyone for joining. We have people from around the nation and around the world, hundreds of people, big accrual today. And also thank my co-speakers here today, Dr. Mehmi from Angeles, Dr. Fischer, our surgical oncologist, Dr. Smithy from Memorial Sloan Kettering, Dr. Cohen, who's joined us here at Angeles, but from Hadassah, Dr. Sullivan from Mass General, and of course myself. I'm the co-director of cutaneous malignancies here, along with Dr. Ferries, who's off spreading the word at this time. This wouldn't happen and couldn't happen without the involvement of AIM at Melanoma, and I want to thank Sam Guild and Ann Taylor for allowing us to partner to bring this educational event forward. Ann, you're muted.
Thank you. Thank you, Dr. Hamid. AIM at Melanoma is delighted to be co-hosting this symposium with the Angeles Clinic and Research Institute. And I want to thank you so much for serving as our moderator once again for the 16th year. And of course, thank you to all of our panelists. I am Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma, and I'm going to have an opportunity later on to tell you about our foundation. But for now, what I'd like to do is talk about our live Q&A session that we have planned for the end of the presentations. If you are joining us on Zoom, then what you'll need to do is you will have an opportunity to ask questions. Some people have sent them in early, but if you'd like to ask a question during the course of the presentations, look at the bottom of your screen. You'll see a Q&A tab, and there you can type your question, and Dr. Hamid will see it. Several of you are joining us through our Facebook and YouTube Live platforms. We welcome you. You can put your questions into the comment field, and then we will transfer those questions over into Zoom so that Dr. Hamid sees those as well. And with that, I will hand the symposium back. Thank you so much.
Thank you so much again, and a grateful thank you for everything you've done for the patients and for advocacy, and also through your IMWG. We wanted to begin from the beginning. As we have moved on from making inroads into the metastatic setting, we now can talk about adjuvant and neoadjuvant therapeutics. And for this, we have Dr. Mehmi, who's part of our cutaneous cohort here. Please. All right. You have to mute yourself. I'm muted. Are you muted? Okay. Okay. All right. Sorry about that technical difficulties. So I've given the task to go over early stage melanoma and its medical oncology related therapeutic approach. But before I start that, wanted to thank both Ann and Sam for doing wonderful work with the organization AIM at Melanoma. It's been going on for years. I think through their effort, number of patients have gone to live a long life. So appreciate you doing the work. And again, always thankful to my mentor and my partner in crime, Dr. Hamid, who's brought me along for a while and taught me the ropes. And also welcome to the rest of the team here. So we'll start off with some of the neoadjuvant and adjuvant sort of approaches to melanoma. And
To start with, I'm going to try to obtain my objectives by talking about the adjuvant therapy for high-risk node-negative malignant melanomas. We'll talk about node-positive melanoma and adjuvant therapy approach and what are some of the future trials and where we're going. And also the newer paradigm in node-positive melanoma with neoadjuvant therapy, current standard of care, and what are some of the future studies that are planned. And we'll talk a little more about what's upcoming. And what I wanted to also include on this slide is the lapse in time since 1970 to current, and how much has happened since about 2005 and onwards, a number of therapies that have come into light and have extended patients' life and improved their quality of life through clinical trial participation, through ongoing research that we continue to take strides in at the Angeles Clinic. So rather than going back and talking about the epidemiology of melanoma and all that, I wanted to dive in right into, where is immunotherapy indicated currently for melanoma. When we're looking at immunotherapy in early stage melanoma, I'd like to divide those patient subsets into about 3 groups. One group will be high risk for recurrences, node negative patients. Those are your stage 2B and 2C patients. And then you'll have the node positive stage 3 patients who've already gone through surgery. And the third cohort will be the cohort that is node positive, clinically node positive, or on scans there have lymph nodes positive disease, and how to approach them. So to start off with, we've got 2 large randomized clinical trials that have guided our therapy for stage 2B and 2C. These are the patients who have skin-limited melanoma, but relatively a thick lesion deep into the skin. And once it's surgically removed, their risk of recurrence is about 20 to 30% for stage 2B and 2C. And that risk can be reduced with immunotherapy, for example, either with Keytruda or Opdivo. Those are the 2 anti-PD-1 monoclonal antibodies that are very well tolerated. And typically we treat for 1 year. The dosing can vary from every 2 weeks to 3 weeks to 4 or 6. For example, Keytruda is highlighted here. It was a 976 patient randomized study to placebo control with intent to treat population. Most of the patients with median age of 61, a good cohort was female population. And at the first interim analysis, it showed that you can reduce the risk of recurrences by about 35%. And at the second interim analysis, that benefit held. And additionally, there have been subsequent updates in this data showing that not only you're reducing the risk of recurrences in a local regional fashion, meaning in the area where the surgery happened and in the nodal basin where the potential nodes could be metastasized to, but disease away from that area is also, that risk of recurrence is reduced, which is distal metastatic survival. That is also improved. Overall, these therapies are very tolerated. Typically, we tend to see mild fatigue, some joint aches and pains, muscle aches and pains. Sometimes we will run into some thyroid problems, but overall, well-tolerated therapy that continue to benefit our patients. What if you're looking at a patient who has lymph node positive disease and they've already undergone surgery? That lymph node could be either on the scans or by pathology report once they've had the surgery, for example, on sentinel lymph node. We've got about 3 different trials that looked at improving the recurrences in these patients. And the first ever trial was the ipilimumab study against placebo. This is the only trial in melanoma in adjuvant setting that's demonstrated overall free survival benefit, compared to placebo. No other adjuvant studies actually have matched that or come close to showing that overall survival benefit. The primary endpoints for this particular study was relapse-free survival, and it met its endpoint. And then secondary endpoint was overall survival. The challenge with ipilimumab in adjuvant setting is the toxicity. 54% of the patients on ipilimumab had grade 3 or 4 toxic events that predominantly focused on the gut, also skin, and a number of other toxicities are possible. So because of that, this is not one of our favorite adjuvant options. Checkmate 238 is the nivolumab study that looked at 906 patients who were node positive, and it was randomized against ipilimumab. And the primary endpoint for this study was relapse-free survival. Again, met its endpoint with 70% relapse-free survival for nivolumab and about 61% for ipilimumab, with the risk reduction by about 35%. The better thing with this approach was that nivolumab is much better tolerated than ipilimumab. As you can see that the grade 3-4 events, the toxicity events, which are considered fairly serious, is only about 14% with nivolumab and still at 45% in ipilimumab. So this has been, along with Keytruda, our go-to regimens for adjuvant therapy or after surgery therapy to reduce the risk of lymph node positive melanoma recurrences. This is the clinical trial of Keytruda or pembrolizumab against placebo. One of the differences between the Checkmate 238 and Keynote 054 trial is that I think the nivolumab treated trial, that particular trial, did have some high-risk patients. For example, the ones with in-transit metastases, those patients were excluded in the Keynote 054 trial. But again, it did show that there is a relapse-free survival benefit compared to placebo at 75% versus 61%, with risk reduction by about 43%. Again, the toxicity profile is very well tolerable. Any grade 3 to 5 events, about 14%, just like nivolumab, and placebo is 3.4%. So based on these number of studies, the patients who've already gone through their surgery and have had their lymph node evaluated, and they meet the criteria for stage 3 malignant melanoma, they can be offered adjuvant therapies or post-surgical therapies for 1 year to reduce the risk of recurrences. What if somebody is not a candidate for immunotherapy? For example, they have autoimmune diseases or any number of problems, or they're on immune suppressive therapy, or they have organ transplant. What do we do about those patients? And a subset of those patients will have the BRAF mutation. And a while ago, there was a clinical trial called COMBI-AD that looked at melanoma stage 3 that's been surgically extended. Follow-up was completed. There wasn't any overall survival benefit for overall population, but Dr. Long did present the data a couple of years back at ASCO that showed that in BRAF V600E mutation population, stage 3 melanoma after surgery does have some amount of overall survival benefit. Thus, we use that particular data to treat some of these patients when we know we can't use the checkpoint inhibition in the patients. So this is something available to us. So now our practice is to check BRAF mutation in all of the stage 3 and obviously stage 4 patients. In the future outlook is very good for adjuvant therapy in melanoma, especially for the node positive disease, based on the Moderna mRNA 4157 that was given with or without pembrolizumab, against pembrolizumab in combination. And the phase 2 data has been presented for a while, and it's been updated. And the phase 3 study that included also the stage 2B and C has been completed, and we're waiting for the data. But the phase 2 data shows that there is a improvement in relapse-free survival when we are comparing the Moderna mRNA vaccine given with pembrolizumab versus pembrolizumab again, the relapse-free survival benefit bumped from 62% to 78.6% at 18 months, and that data has been updated, and this benefits have held so far. And luckily for us, adding on the mRNA vaccine did not add any significant adverse events to these therapies, so the patients are able to tolerate these therapies. So we're actually looking forward to the Moderna or Merck data on this combination, and look forward to its possible approval in the future. So now, what if we are seeing a patient who hasn't gone through surgery, but they have their lymph node intact, meaning the lymph node that is melanoma has metastasized to, it's still present either on the scan or by physical exam. Is there a different approach to that? And the reason for that is this cartoon shows that when we remove a tumor or a lymph node from the body that does have melanoma present in it, it does not allow the immune system to react to it the same way as if that lymph node was still present in the body. You can see here that when we give these immunotherapies, immune checkpoint blockades, it interacts with the immune cells already present, but in the absence of tumor, these immune cells are fewer, and they're not as diverse in reacting to the tumor. But when this tumor is intact in the body, we give these immunotherapies, then these the tumor reactive T cells are very diverse, giving us a much better response towards the tumor that we can detect on the pathology. To move this concept further, what are the benefits by doing this neoadjuvant therapy? There have been a couple of trials that have looked at, can we de-escalate or lessen the surgical burden on patient through this approach? And then additional step were that, can we decrease the amount of immunotherapies we're giving these patients to reduce the risk of toxicity? So with those goals, the first trial that looked at was the Prado study that gave patients with lymph node positive disease stage 2B or C, or even de novo recurrent disease, gave 2 doses of ipilimumab and nivolumab, and then had only index the lymph node that was involved in melanoma resected. And if those patients had a very good response to immunotherapy, meaning there wasn't much tumor left, then they were allowed not to go through any further surgery. But if their response to immunotherapy wasn't adequate, then they did have subsequent surgery. And when we look at that, the green part, the green line here is the one of the patients that responded really well. Those are your major pathological response individuals, and they went on to do really well even with the limited amount of surgery. But the ones who didn't have adequate responses are the ones that get in trouble down the road. Overall, these therapies are well tolerated. Again, we did not learn of any new toxicities that come up because of it. So the next step was, we know that Opdivo, Yervo, or ipilimumab, nivolumab is quite toxic, has a number of side effects. Can we reduce, or can we just give one immunotherapy, one drug, and still get to the same spot? And that trial happened here in the US, the SPOG S1801 by Dr. Patel, a large trial of 345 patients that looked at sandwich approach in a sense. One arm got 3 cycles of pembrolizumab, then surgery, and then to complete 1 year of pembrolizumab in adjuvant setting. And the second arm went through surgery first and then had 1 year of adjuvant therapy of pembrolizumab. And the primary endpoint was event-free survival, and this trial met its point. Also, the overall survival was improved. And similarly, there is an option for neoadjuvant therapy using nivolumab and relatlimab or Opdualag. And the challenge is a whole year of therapy again. So the third trial that actually attempted to reduce the amount of immunotherapy in neoadjuvant setting was the Nandina study. And this trial is actually bases our practice, or at least my practice in neoadjuvant setting. This trial looked at node-positive patients, giving them 2 doses of Opdivo Yervoy, and then going through surgery. And if they've had a major pathological response where only 10% or less melanoma is left in that lymph node, then they do not need any additional therapy. And so based on this, we can actually spare a lot of patients for any additional therapy. And looking at this trial, you can see that about 80, the text is a bit small here. When they treated 212 patients, you can see that complete pathological response was in about 46% of the patients. And those are the patients that go on to do really well. And you can see that the event-free survival is very good for these patients. The panel here on the far right is the recurrence-free survival for patients who had a major pathological response or complete response. 95% of those patients go on to have no recurrences at 18 months and beyond. And the data is much more mature now, where we have 3 years follow-up data that these patients continue to live without any recurrences. The patients who have partial or very little response in the node or to their melanoma are the ones that require additional attention and subsequent adjuvant therapy. Of these patients who have BRAF mutation, we elect to use those targeted therapies to keep them recurrence-free, or at least attempt it. The ones the ones who do not respond in this fashion, or they're called pathologically non-responders, those are the ones that require much more attention. Their risk of recurrence is much higher in the very near future, and those are the patients that we attend to by using a number of different clinical trial options and continue to help them.
Okay, that's it.
That's it.
All right. More slides. Okay, so that is fantastic in a way that we can utilize. Stop sharing. We can utilize the drugs that we have worked on so far in order to help our patients. Obviously, the goal of these talks is to allow us to understand some of this, to bring in forth between patient and physician discussions. Also, those physicians include surgical oncologists, and I have the pleasure to introduce you to Dr. Trevon Fischer, who I've known since fellowship with John Wayne with Dr. Morton. Dr. Fischer has joined our practice and is really helpful to explain and take our patients through the neoadjuvant and adjuvant paradigms as they have questions and need someone to guide them surgically. So Dr. Fischer, please.
Well, thank you, Dr. Hamid, and thank you to AIM for allowing us to speak. And this will be my first time speaking, as recently joining, but I have definitely listened to these lectures in the past and always found them to be very enlightening. So move forward. So I wanted to talk a little bit about how did we get to neoadjuvant therapy for melanoma from a surgical perspective? And then secondly, does surgery play a role in the era of effective systemic therapy? As Dr. Mehmi mentioned, all these great effective and well-tolerated systemic therapies. Now, how does this play a role in from a surgical perspective? So first, when we think about historical surgical treatment of melanoma, we think of kind of two areas. Early stage melanomas, we think of surgical excision and evaluation of the lymph nodes. And that's done with a wide local excision, as you can see kind of depicted here. Depending on the depth of the melanoma, we take a margin that usually, depending on where it's at in the body, we're able to elongate that circle into an ellipse and close most of these with a linear closure at times needing to do skin grafts or complex reconstructions. And then in a certain subset of patients, we also want to test the lymph nodes at the time of surgery. And that's done currently by using tracers at the time of surgery, and some done in radiology the day of surgery, where that tracer will move to the side of the first lymph nodes that would see the metastasis had the melanoma spread. And then we were able to use a couple of different techniques in the operating room to identify that lymph node and remove that, instead of excising the whole basin, which could be a much more morbid procedure with complications of lymphedema, wound healing, and cosmetic issues down the road. Before we developed the standard margins were very wide. So in the 1970s and before, started off at 2 centimeters. Some people said 5 centimeters. There were people who even advocated for 8 centimeters, and one study looking at 15. And a famous surgeon from Italy said just as wide as possible. And so basically, everyone at this time got skin grafts, which had issues with healing. Through a whole host of studies over the 90s and early 2000s, the current recommendations are as follows here, and pretty standard since over the past 25 years. Kind of the theme of the talk, I would say, is how surgery has gotten in the early days has been a big part of this with big surgery, and as we learn more, we can kind of narrow in our surgery both in scope and in size. One of the things that's coming out new with surgical margins is the MELMART trial, and this is a trial that has just recently reached its target enrollment, over 3,000 patients that successfully closed to recruitment in late last year, and it's looking now for these stage 2 patients, so ones that you would previously have done a 2 centimeter margin on, is doing a 1 centimeter margin okay as well. And so we anticipate a few more years of data collection and follow up to see if we can identify if doing less surgery even than the 2 centimeter margin would be appropriate. So we made a lot of progress in limiting the morbidity of the surgery, and with good research, we found that we've not sacrificed any of the oncologic outcomes. Next, I want to just kind of briefly go through kind of the landmark trials and the nodal evaluation so that we can get to some of these neoadjuvant approaches that Dr. Mehmi had talked about. So first, MSLT1 was a multi-center international trial. And it really, to boil it down, does a sentinel node biopsy improve outcomes? And so prior to this, patients were having elective lymph node dissections where the whole basin was removed, and at times you would get 20, 30 lymph nodes, and many patients would have no positive lymph nodes, and they would have a surgery that eventually gave the information that we needed, but also had a much bigger comorbidity to the surgery. And so what this study showed is that the sentinel node biopsy can accurately stage the regional lymph nodes, found that positive sentinel lymph nodes were associated with the worst prognosis both in disease recurrence and death from melanoma. You can see it's the highest risk of recurrence and highest risk of death when looking at all of our standard characteristics that we receive from a path report. It also improves regional disease control. Approximately 70 to 80% of patients with the positive sentinel node, only nodes that will have disease in them are the sentinel nodes. And so doing more surgery may or may not provide any benefit. And so this really did establish the sentinel node biopsy as the standard for staging for intermediate and thick melanomas. And that was started in the 90s, and this was published in the around 2014. Indications to test a lymph node for our early stage patients is if the risk is greater than 5 or less than 5%, we don't recommend testing the lymph nodes. So these are our thin melanomas without any adverse features. I always caveat that with sometimes There could be a deep margin that's positive, and we don't know how deep the melanoma is at its initial presentation, or it could be limited by sampling of a small biopsy of a larger lesion, and that risk we may not know until we do a full excision. If that risk is between 5 and 10%, we discuss and consider, and that's patients who have a young age, head and neck location, lymphovascular invasion, or a mitotic rate greater than 2. And nowadays, our friends from Australia have developed a risk calculator that is used. There are other ones that are out there as well. And we can use this to look at a patient here who we calculated as a 20% risk. So this is a 75-year-old patient with a 0.6. So technically, by those characteristics, less than 0.8, so it's a T1A. We may not recommend a sentinel node biopsy, but given that the patient has 2 mitoses and lymphovascular invasion, their risk is actually 1 in 5 that their sentinel node would be positive. We changed that up to keep only no lymphovascular invasion in the same patient, and that risk can go down to 5%. So we use these to help us determine what patients need a sentinel node. And in the same patient now with no lymphovascular invasion, let's change their age to now a young patient, 35-year-old, and see that risk can go up to 15%. So all these factors play a role in who we determine need a sentinel node. And we use those in the clinic daily to help discuss this with patients. So next, so MSLT1 basically established that sentinel node as a standard staging for intermediate and thick melanomas. Now we want to know, do we need to now go back and do a completion lymph node dissection if the lymph node was positive? And so this question was asked through MSLT2. And what it showed, as patients were randomized to an immediate node dissection versus an observation, is that as you can see here, these curves basically overlap the whole way. And so immediate completion node dissection did not improve melanoma-specific survival. This was also shown out of Germany in another group that was published at the same time as this, 2017. This really did change our practice from surgery. So we're backing away from doing more surgery, just as we backed away from doing more surgery at the primary site. They did find that the completion dissections improved regional nodal control, which makes sense. You're taking out those lymph nodes, and was associated with more morbidity and lymphedema when we did more surgery. And so at this time, active surveillance became the standard for many patients. I wouldn't say all, because there are patients who may benefit from this, and that's where some ongoing research is still happening. So MSLT2 then developed an active surveillance. Where neoadjuvant approach comes into is in MSLT3, and this is a new trial that is enrolling patients in Australia and is soon to be starting here in the U.S. and other places. And this is looking at after neoadjuvant immunotherapy. So those approaches that Dr. Mehmi had spoke of previously, do we still need to do a full therapeutic lymph node dissection, or could we do a smaller, more limited dissection, get the information to the pathologist so that we can use that to then decide what's next? Do we do more surgery? Do we change their systemic therapy? And so this trial, again, we don't have any answers at this time, as it's currently enrolling, but it will ask basically whether excellent responses to immunotherapy will allow us to do safely less surgery. So again, and now the neoadjuvant setting, where the standard currently is to do a full dissection around the nodal basin where the node has either been biopsied or excised with other additional nodes being positive. Can we pull back our surgical treatment without sacrificing any risk? So at this point, moving from neoadjuvant to think about what the role of surgery is in the metastatic setting, and some of these questions go through our head. Are we helping? What's the risk of surgery? How well are they responding? Is this just a palliative type procedure, and we're helping just from a pain control standpoint? And so really, why operate at all? Historically, stage 4 melanoma didn't have a lot of systemic options, and so surgery was really seen as one of the only therapies capable of producing some durable control. This typically happened in patients with limited metastatic burden, so small volume disease, those who might have had a long interval from when their primary was noticed, surgically excised, and then recurred years later. How the tumor doubling time, how the tumor is growing, and then obviously for any surgery, we have to look at the patient to see what their performance status is. And we really found that early data suggested that if in carefully selected patients, there was some prolonged survival, and that probably complete resection mattered more than just surgery alone. And so really finding those patients that we could completely excise were important. What's the role of surgery in the immunotherapy era? So now we live in an era where we have effective systemic therapy, both immune and in targeted therapies. And so how do we adjust our role as a surgeon in this setting? And so there are several potential roles, removing residual resistant disease or consolidating or getting a response after immunotherapy that is similar to what we see in the neoadjuvant setting to be able to assess how well the therapy has worked under the microscope. Potentially there could be patients who have small volume disease that's progressing where everything else is either stable or resolved. And that may be a good indication to get surgery back involved to see how we can help. And always with really any cancer that we deal with, the melanoma and others, surgery does play a role in palliation. And so we all know that melanoma can go to the GI tract and cause a bleeding that requires transfusions. If we can identify which lesions are bleeding, doing a surgery in those scenarios are helpful to get patients back on therapy and out of the hospital. Pain is something that can happen anywhere a tumor can be growing, and sometimes we're able to surgically provide some relief for that. And then as the GI tract obstruction can happen, and dying from a bowel obstruction is a really terrible way to die, and sometimes we're able to help just from palliate those symptoms. One other new area, and I think we'll be talking about this in a little bit, is obtaining tissue for molecular testing and TIL. And so that's something that surgeons play an important role in. And so this has really been a shift. We no longer think of surgery as can we do it, and maybe it's the only thing we have. And it's often integrated into systemic therapy and really plays a role in the multidisciplinary discussion of these patients that happen. So who is a good candidate currently? It really comes down to patient selection. Favorable features or small volume of disease, kind of diseases controlled elsewhere. And I think more importantly, now that we have effective systemic therapy, is how did they respond? Are they progressing through systemic therapy, and is surgery likely not to provide any value unless it's done for some palliative reason? The ability to achieve complete resection is always important when we think about doing metastectomies. Common surgical sites are listed here. As we know, melanoma can go anywhere. And these are some areas where we do find ourselves needing to step in and help out our patients. So we may kind of to summarize, selected patients with isolated or resistant lesions, patients with symptom control, and when those who have had a good response to systemic therapy, I think there are still some roles for surgery in this setting. And then finally, I wanted just to say some surgical considerations in TIL therapy. Viable tumor is critical, so we need that active immune infiltrate to get to the lab to be able to populate these TIL cells. Necrotic tissue is bad. A lot of scarring or heavily pretreated lesions with radiation have been shown to not grow well, and so it's not just size. Not a larger lesion is not necessarily better as if it's not viable. And we use PET scanning and other things to try to help predict that, but sometimes you just have to get the tissue to the lab to figure it out. Preferred sites, soft tissue and subcutaneous metastasis are often easy to remove and have lower morbidity of removing as are lymph nodes, and typically are often highly cellular and have a high immune infiltrate. More challenging sites would be the liver, both from a technical standpoint and and I think for an immune environment. Those have been challenging sites to grow TIL from. Obviously, the brain metastases are not pose a higher surgical risk. Bowel lesions can be have issues with contamination. And so really want to choose the site that is most likely to yield a viable active tumor with the least risk and fastest recovery. So my take-home message from a surgical standpoint is, melanoma surgery has evolved from maximizing the amount of surgery to maximizing the value of the surgery. That's all I have.
Very lovely. Learned a lot here about how to speak to the surgeon, and a great talk about what makes sense and what doesn't make sense. Our next speaker is Dr. James Smithy, who has joined our team and our group from Memorial Sloan Kettering Cancer Center, which has a huge history of putting out phenomenal oncologists who just continue to contribute. And for us here, we're contributing to one of his studies, but really would like to hear more about the emerging cellular therapies, as T-cell therapies have now taken us by storm. So welcome and thank you.
Great. Thank you so much. Can everyone see my screen appropriately? Looks okay?
Yes, do you want to
Go
take it out of presenter mode and put
Yeah, I'll
it
switch.
into...
I'll switch it. I wasn't sure. Is that better?
That...
Looks good?
Yes,
Okay.
that's perfect.
Well, thank you, Dr. Hamid, for the introduction, and thanks so much for the organizers for the invitation to speak. Thanks also to AIM, for all the wonderful work they do for the melanoma community. So, we heard already some really exciting data from Dr. Mehmi and Dr. Fischer about how, immunotherapies transformed outcomes for patients with melanoma. We have patients with stage 3 and even stage 4 disease who are effectively cured with these. But I think an ongoing challenge in our field has been, how do we treat patients effectively where immunotherapy either didn't work up front or it stopped working, and what are our next best, options? And so I think really over the last 5 or so years, we've seen cellular therapies take the fore as like one of the potentially most effective durable treatments for patients. And so we'll walk through, some of the background there and both the clinical and, translational considerations. Here are my disclosures. I think relevant to this talk, I do, have research funding from Maddox and from Iovance. Okay, so just to set the stage, I think if there's one slide from this whole presentation that you should remember, it's this one. It's framing the two big groups of T-cell therapies for melanoma. And so you hear a lot about TIL. Dr. Fischer started to talk about this as well. And this is sort of our state-of-the-art approved therapy that we have available right now. And the other one is TCRT, which is a more of an engineered or bespoke approach. So TIL, like we heard a little bit about already, we need to get tissue from surgery or biopsy to really harvest and expand the T cells that are already trying to fight the tumor. This is a polyclonal product, so there are many different types of T cells in there. We're not selecting for one particular one, and we don't really know what those T cells are recognizing, so we can get a bit of a mixed bag. The approved TIL product is lifileucel. We'll talk about a different TIL product that's in development, OBX-115. And for this product, you need to get chemotherapy before to make space for the TIL to grow peripherally. And then TIL typically need to be boosted as well with a cytokine, and we'll get into that later in the talk as well. On the other side, we see TCRT. These are not approved for melanoma yet, but the idea here is instead of harvesting the T cells from the tissue, we are able to pherese T cells from the peripheral blood and then engineer them to target a specific antigen, a melanoma antigen. So the product we'll talk about most today is Anzu-cel or IMA203. This is probably the TCRT that's furthest along in development for melanoma, and I think has some exciting properties that are a bit different, from our TIL products. Okay, so just to start with some of the background on lifileucel, I think the story for lifileucel really started over 30 years ago at the NCI with the Rosenberg group. We see surgical harvest, lymphodepletion, and IL-2 boost happening back in the late 80s, early 90s. Here's a paper, back from 1994, which is really not all that different from what we're doing today at our centers across the country. However, it took until 2024 in February for lifileucel to be approved by the FDA, and largely this was a operational success in that the supply chain was developed such that TIL products could be cryopreserved and shipped from centers across the country to a central lab and then back to the patient in their town. And this was something that wasn't done. NCI was a bespoke kind of single center that was doing this for many years. So just to recap a little bit of what I talked about, what's in a TIL product. Here's a little schematic of the tumor with a few T cells of different colors embedded. The tumor gets resected, it gets digested, and then you're growing up over several weeks all of these different populations of T cells. So some may be reactive to specific mutations in the melanoma. Others may be reactive to proteins that are highly expressed in melanoma but might be shared by other antigens. One example would be, when T cells after TIL recognize the normal melanocytes in skin, you may see some vitiligo. Those could be those T cell clones that are playing a role there. And then there might be other T cells that are really not doing much of anything and they're just in the mix. And I think we really need to learn a lot more about the TIL products that are going into our patients to understand the breakdown of these different T cell populations and how they are important. And then what does this look like for the patient? Dr. Fischer started to talk a little bit about this, but really the interdisciplinary discussion between surgeons and medical oncologists is so important at the outset of this process. And I really have enjoyed, getting involved in the TIL field because I've gotten to work really closely with our melanoma surgical oncologists. So we will review patients' imaging together. We'll decide what's the best lesion to go for. There are some features, some sites that we prefer, considering operative risk, considering yield. Something we've been trying to experiment with is actually harvesting multiple tumors because there could be different T cell repertoires in different lymph nodes or different sites. And I think there's going to be a lot of data coming out in the coming years of how to optimize a TIL harvest. Once the patient gets through that procedure, it's about a 5-week waiting period where the TIL are produced. And it's usually about 4 out of 5 at this point that are successfully generated into a TIL product. There are times when a patient goes through surgery and we have to go back to the drawing board where we didn't get a successful TIL product and consider harvest again. But provided we get a product in hand, the patient then has to do either 4 or 5 days of lymphodepleting chemotherapy with fludarabine and cyclophosphamide. The point of this is to really reduce the bystanding T cell repertoire and reduce the T cells in the peripheral blood such that when the TIL come in, they can have more energy to expand and kind of have a favorable cytokine milieu. After the chemo's done, the patients get their peripheral T cell, their TIL infusion. This is done usually in the hospital. And then the tough part of all of this is the 3 days after where patients are getting a high dose IL-2 in the hospital. And this is basically like adding the fuel to the fire of the TIL and helping them grow, divide, and fight the melanoma. In general, patients are in the hospital for about a week after their infusion, but sometimes depending on the side effects, it can be up to 2 weeks. And then after that, it's largely about recovery and observation. And the nice thing is that if a response is generated, patients do not need active ongoing treatment after and can just monitor with scans and lab check-ins. So how well does this all work? Here's the first waterfall plot that came out of the C-104-01 trial. This is the registrational phase 2 trial that led to the accelerated approval of lifileucel. And you can see these are all patients that were treated with checkpoint inhibitors, had melanoma that was resistant to checkpoint inhibitors, and the overall response rate was 31%. So all of these lines represent the degree of shrinkage in different patients' tumors. And this is a pretty, I would say, impressive response rate in this heavily pretreated population. About half of the patients in this trial got combination nivolumab and ipilimumab, and many patients had BRAF mutations and had already had BRAF MEK inhibitors before. So I think one thing about this population is a little bit younger than our average melanoma population, about 10 years younger. So we're working on trying to determine the safety of this approach in older patients as well. How toxic or what does the side effect profile look like with TIL? It's basically what you would expect with the chemo and the IL-2. It's a lot of acute toxicity that's fairly predictable in the first few weeks of treatment, where you do see a lot of reduced blood counts, you see fevers, you see a lot of inflammatory side effects. But the nice thing is that it's all very concentrated, usually during the first week after infusion and after IL-2 is finished. The incidence of late adverse events happening after a patient goes home and goes to the hospital is very low. I think in the early days, we thought this might look like CAR-T, where patients do get late inflammatory syndromes. We're not seeing that so much now. And so really, once you get a patient through that acute inpatient hospitalization, their outcomes tend to be quite good from a safety perspective. And then, addition to safety, how long do these responses last? What do those, look like in the long term? And this is data from the 5-year follow-up of the C-104-01 trials published in JCO last year. It's really encouraging that about, half of patients that had a significant amount of tumor shrinkage still had ongoing responses 3 or more years on. And so there are patients who are, we think, effectively cured with TIL. And I have some personal patients who are more than a year out whose tumors are still shrinking, which is really rewarding with no additional treatment. And so if you do the math, this works out to about 1 in 6 people who receives a TIL infusion. And I think a lot of work we have to do is figure out how to get that number higher. The patients that are most likely to have a long-term response include those that have a lower disease burden, so smaller tumors. We think there's a trend with a higher number of infused cells, like that might be a promising feature of the infusion bag. And then less treatment before is actually also associated with long-term response. So I think this is a really important thing to think about both for patients and their doctors, is that if you would consider, cell therapy at some point in the time of your treatment, it might be better to do this, shortly after immunotherapy is not working, and perhaps not try, 3 or 4 other treatments before and then save TIL as, a last line treatment. I think that's how we're seeing the TIL be used most effectively. Okay, so just to pivot, from lifileucel to an engineered or next generation TIL product, this is OBX-115. I mentioned, lifileucel, we're just growing whatever's in the tumor. There's no genetic engineering happening. OBX-115 is a slight variation on that. So tissue is still harvested as it would be from lifileucel, but then the cells are actually modified with this gene cassette. And so this is a genetic, a kind of module that's put into the genome, and it basically transcribes this therapeutic protein attached to a drug responsive domain. And so what this red domain does is it targets this protein for degradation. So if you don't give the patient any additional medicine, this whole construct will just be broken up by the proteasome. It will never be expressed. It will never do anything. And for these cells, the orange protein one we're trying to express is IL-15, which is an immune activating protein. So if you don't give the patient anything, this IL-15 never gets expressed and the cells don't get activated. However, if you give the patient a drug called acetazolamide, which is just a simple diuretic, it actually stabilizes that drug responsive domain in red, and the whole protein complex gets expressed up on the cell surface. So this IL-15 is able to express at this, and it can activate the cell, it can activate other cells nearby with sort of autocrine and paracrine signaling. So this is really exciting because, for lifileucel, we have to give the high-dose IL-2 in the hospital. Here, patients are able to take acetazolamide, and they can do it either in the hospital right when they get their cells, or they can potentially take it later on, when they're home months later, and re-stimulate their cells. So this is still very early, development program, but we are seeing some promising early results. This is some data from the phase 1 trial that was presented last year. And you can see like over half of patients with the recommended phase 2 dose of OBX-115 did have significant tumor shrinkage. There's going to be some more data presented at ASCO in a couple of weeks with more patients. Excited to see that, but I think what we know so far is pretty promising, and this might potentially be a more effective treatment than lifileucel. Okay, so now in the last couple of minutes, just want to pivot to our TCR-T side of things and talk a bit about Onzucel. This is an engineered T cell, and it's pheresed from the peripheral blood. And so to engineer a T cell, the first question is, what are you targeting? What is a good antigen? And so this is a PRAME-targeted T cell. And so PRAME was discovered back in the late 90s, actually, by studying T cells that were reactive to melanoma. It stands for preferentially expressed antigen in melanoma. And it's really, I think, highly expressed in many melanoma subtypes, a little bit less in desmoplastic melanoma, but across other melanoma subtypes, very, very common to be expressed. It's not really expressed in any other normal tissues, but very low levels in the testis, ovaries, adrenals, and placenta. So there hasn't been a lot of off-tumor activity of this product so far. On the right side, you can see some of the rates of PRAME positivity in many different types of melanoma. Cutaneous, it's 95%. Really exciting, it's 90% in uveal melanoma, and we've had a really hard time getting effective immunotherapies to work in uveal, and this seems to be a potential target here. Also a number of GYN cancers and lung cancer as well it's expressed in. So what does the Onzucel or IMA203 actually look like? So this is the small T cell up here. We have a melanoma cell on the bottom, and so there's an engineered TCR that binds PRAME in the context of a patient's HLA. So we'll talk about that in a second. So CAR T basically have to bind proteins on the surface of the cell, but that doesn't allow us to target any proteins that are inside the cell. For any protein that's inside the cell to be recognized by the immune system, it has to be broken up, chewed up, and then it has to be placed on one of these antigen presentation machines. So HLA is one of those, and HLA-A0201 is one version of that machine that some people inherit from their parents, others don't. So about 40 to 50% of patients with melanoma have that particular HLA. So if a patient has that HLA type, they express PRAME, we would expect Onzucel or IMA203 to recognize that. Here's some layout of the phase 1 trial that was done with IMA203. Patients got PRAME tested, they got HLA tested, had to be positive for both of those. The patients got pheresis, so their peripheral bloods were filtered. IMA203 was made in about 2 weeks, so pretty quick turnaround time. Then patients got that same lymphodepletion, a little bit lower than with TIL, got their IMA-203 infusion, and then got low-dose IL-2 just injected under the skin after infusion. And I think the data from this trial are really quite exciting, and one of the most exciting waterfall plots for PD-1 refractory melanoma that we have currently. For skin melanomas, about half of patients had a confirmed objective response. For uveal melanomas, this is really exciting. 2/3 of patients had a confirmed objective response, and then a few mucosal and melanomas unknown primaries also had responses as well. So there's a large phase 3 registrational trial going on now, where about half of patients are getting IMA-203, half of patients are getting standard treatments, and that includes TIL. So this will be one of our first trials that's comparing, cell therapies head to head. And we're excited, to participate in this and see the results of this, in the coming year or two. Last slide I just want to share is, could we combine, cell therapies with other types of treatments to make them even more effective? So this is a phase 1 trial we're leading here at Sloan with IMA-203 that's then boosted with actually an mRNA vaccine, because you can give cells, and then what if you vaccinate the patient against the same target afterwards? Could that lead to deepening of the response? Could it lead to broadening of the immune response against PRAME? So this is a very small study. It's just going to be 16 patients to start, but excited to see some data from this in the next year or so as well. So that's the kind of where I wanted to wrap up. Lifileucel is sort of our state-of-the-art now as an approved cell therapy for melanoma. It's the first cell therapy for any solid tumor. OBX-115 and Anzu-cel, I think, are two promising investigational approaches. And then maybe combinations of cells with other types of immune-stimulating drugs might be something we see more of in the coming years. So thanks again for your attention, and look forward to the questions later.
It's wonderful. Thank you so much for that. We'll now move on quickly to Dr. Jonathan Cohen, who has joined us from Hadassah Center in Israel. He's a senior medical oncologist and decided to leave there and come and spend a year with us to work on clinical trials, first-line, second-line trials, and investigator-initiated trials, and has brought a great flavor to the way we take care of patients here. Jonathan, thank you so much.
Thank you, Dr. Hamid, for the invitation, and thank you to the organizers for giving me this opportunity. So I'm going to talk about first-line treatments in melanoma, and chronologically, these appeared before most of the things you've heard about today. So we will take a bit of a step back to show how things progressed. Okay. These are my disclosures. I just mentioned that I'm not licensed to practice in the US. So just if we want to see what the progress is that we've made, so just over 15 years ago, we were treating patients with advanced melanoma with chemotherapy, and chemotherapy really didn't lead to a meaningful benefit to patients at the time. And chemotherapy directly kills the cancer cells, the melanoma cells. And that's what we had at the time. I'd say that there may be a second chance for chemotherapy in certain scenarios in the future, but it's been phased out since due to the advancements. And really, the new advancements in advanced melanoma brought us to a point where we're looking at long-term survival and even cure for advanced melanoma, which was really unthinkable not that long ago. And really, the two pillars that provide this advancement in treatment are the precision oncology and the immunotherapy. So the precision oncology, or the targeted therapy, which Dr. Sullivan is going to talk about, so I'm just going to touch very superficially, is a way of treating cancer by finding a pathway that is active in a cell and is critical for its function. If you can block that, then you can stop or kill the cancer cell. This type of therapy in melanoma is appropriate for a subgroup of patients who have a mutation in a gene called BRAF. The focus of my talk is going to be on the immunotherapy, where we restore the ability of the body to fight cancer itself. So we move from killing the cancer with an external agent, the chemotherapy, using the body to treat the cancer itself. I'd like to give a brief background on how these drugs work. And really what we're doing is we're taking advantage of something that we all have in our body, which is the immune system. And the immune system is there to help us fight germs, bacteria, viruses. And without it, we would succumb to infections quite immediately. So an infection is treated like that, and inflammation, which gets rid of it, is a positive thing. But a chronic inflammation, ongoing activity of the immune system, is a bad thing. It causes tissue damage, and even in some cases, it can cause cancer itself. So what the body has is a very sophisticated system to let the immune system be active on the short range to eliminate the infection, but then tune down so it doesn't cause chronic inflammation. And what does that is, or one of the elements that allows shutting down the immune system, are called checkpoints or immune checkpoints. And these are a kind of brakes that, when activated, stop the immune cells from killing their targets. Now, cancer cells manipulate these checkpoints to evade the immune system. So it turns out that the immune system has the ability to identify the cancer cells as being foreign and attack them. But by triggering these immune checkpoints, the cancer cell can shut down the immune system and survive despite this potential of the immune system. So here's where the immunotherapy, the immune checkpoint inhibitors, come in and fix this break. And the backbone in melanoma of immune checkpoint inhibitors are the PD-1 blockers, the nivolumab and the pembrolizumab. And there are other drugs that are registered in other cancers. And what these drugs do is they block these breaks. They block the PD-1, which is an immune checkpoint. And by blocking that, they reinvigorate the immune cells to attack the cancer. So just to show an example of what we might achieve with such drugs, a patient we treated back in Israel several years ago. And this was a patient treated with another type of immune checkpoint, ipilimumab, which you've heard of before from Dr. Mehmi. And you can see in 2012, these white ping pong balls in the lungs are metastases of melanoma. And the patient was treated with 4 cycles of ipilimumab, which was given over 3 months, and stopped and never given again. And in December 2012, you can see just a very small remnant of this. And then moving ahead to 2014, a year and a half later, there's no evidence of the melanoma, and it was gone. And the patient was followed for many years afterwards with no recurrence of the disease, without need for any treatment in the meantime. This is an exceptional case, but there are many cases like this and other very good and long-term responders to such treatments. And so we saw very good responses to ipilimumab and very good responses to the anti-PD-1s. And then, of course, the question was, could we do better? And in order to do that, the study tried to combine these 2 drugs, nivolumab and ipilimumab. So if we're talking about 2 drugs together, it's worth mentioning the 2 scientists who brought us these drugs and got the Nobel Prize for it in 2018, Dr. Allison and Dr. Honjo. And they deserve a lot of respect for curing many patients with melanoma. And we have a very long follow-up of this study, which combined these drugs together. And we've already had a 10-year follow-up report from this trial. And we really see a very significant increase in patients who survive 10 years after the diagnosis of metastatic melanoma. And just for comparison, if we're talking about the era of chemotherapy, at best, that would be at the low single-digit number and maybe less than that. So really, there's an option here for very long-term survival and maybe cure for many patients. I would mention that it was also found in another 2 studies that this combination of ipilimumab and nivolumab is active in brain metastasis as well under certain conditions, which is also a huge benefit since we know melanoma has a tendency in many cases to spread to the brain. The trade-off for this increased efficacy is a higher rate of side effects. And we know that with this comes a high rate of severe side effects, which we do know how to handle, but do require vigilant monitoring. So the next step, which just arrived a few years ago, was a new drug that blocks another checkpoint called LAG3. And the drug that blocks is called relatlimab, and it's given in combination with nivolumab. It's called Opdualag when it's given together. And this drug, again, was compared to the PD-1 alone and showed an increase in benefit. So we don't have as long a follow-up as we do for the ipilimumab. But we do see, and you can see the separation of the curves below. The blue curve is in the center, is the combination drug, and you can see that there is a separation in favor of the combination. So the combination does better, and the trade-off is not as bad. So there is an increase in side effects, but that increase is not as significant as what we see in the combination with ipilimumab. It is important to note that there is no, unfortunately, direct comparison between these combination drugs, but the data seem quite convincing to show that ipilimumab in combination with nivolumab is more effective than relatlimab and nivolumab, and the same for toxicity. It seems quite convincing that the ipilimumab combination is much more toxic. So being aware of these side effects that could accompany these drugs is very important because we have ways of coping with it, and the earlier we cope with them, the better. So what these drugs do is, beneficially, they trigger the immune system to attack the cancer cells, but with that, we sometimes get an unwanted activation of the immune system against healthy tissues in the body, what we call an autoimmune reaction or immune-related adverse event. And despite these adverse events, it's clear that the benefit outweighs the potential danger here. And I would contrast here what Dr. Mehmi was describing before, since the scenario of providing these drugs in the adjuvant setting when a patient doesn't have disease is different from giving these drugs in the scenario of advanced disease. So the willingness to take risk is obviously larger when there's a disease we have to treat than if we're preventing disease, and potentially some of those patients whom we're treating don't even have disease and it wouldn't recur even without treatment. So in the scenario of active disease, we're willing to take a certain degree of risk in order to provide long-term benefit. And again, Dr. Mehmi mentioned some of the organs that are involved in autoimmunity, but in general, really almost any organ in the body could be affected. These are some of the more common ones: the thyroid, the gut, the liver, lungs, and skin, and others as well. I would say, as was mentioned before, that when we give PD-1 blockers alone, tolerance is very well. And I also mentioned that for many of these toxicities, it's evident in laboratory or imaging, and patients don't immediately feel the effect, so we can often identify them early and treat them before it causes a significant impact on quality of life. And we do have a very effective means of treating these toxicities. The first agent is usually corticosteroids, but we definitely have other agents as well. So the rule of thumb is that early recognition and prompt treatment of side effects are critical for success. And because of that, it's important that anyone who's receiving immune checkpoint inhibitors be aware of any changes and consult the oncology team in order to address these in a timely manner. What about stopping treatment? And I mentioned the case of a patient who was treated with only 4 cycles of treatment and seemed to have been cured. That's not the case for the PD-1 blockers, which we usually give for a longer period of time, but does it have to be a chronic medication that you take for life? And the answer is that usually no. In many cases, we can stop the treatment. The 2-year benchmark is very well validated, and some of the studies gave the drug for 2 years, and we have the follow-up on many patients who received the drug for 2 whole years and then were followed up for more than 2 years afterwards. And we see that many or most of the patients did very well even after stopping the drug. The better you did on the medication, the better off you are after stopping it. So if you're in complete response, the melanoma disappeared completely, then the chance of recurrence is very low. If the melanoma became smaller, it's still pretty good, but not as good. If the melanoma didn't become smaller but didn't grow, what's called stable disease, it's not bad, but it's not as good. So the depth of the response, how well you responded to treatment, will often help guide us in the timing of stopping treatment. And because of what I just mentioned, in cases of complete response, when the tumor completely disappears, we often feel comfortable stopping the treatment earlier. It might be a year, it might be other, depending on how you tolerate the treatment and other considerations, but there are definitely scenarios in which we stop the treatment earlier. One last scenario where we stop treatment is the case of side effects. We don't always stop treatment for side effects, and after side effects, we'll often try to re-challenge with the drug with various means to reduce the risk of flare in the side effects. But sometimes the side effects are significant enough that we feel the need to stop treatment. And we have data which is very encouraging to show that patients who had side effects, it's an indication that their immune system was very well activated. So while it doesn't guarantee if you had a side effect that you will respond against the melanoma, it actually increases the chance that that will happen. And when we compare patients who had to stop treatment because of side effects to those who didn't have side effects at all, even though patients stopped treatment, they still did better than those who didn't have side effects. So if we have to stop treatment for side effects, that's okay. Now, I said that Dr. Sullivan will talk about targeted therapy, but I can't avoid discussing the room for targeted therapy in first-line treatment of advanced melanoma, because for many years there was a debate if a patient has a BRAF mutation, therefore they're eligible to targeted therapy or immune checkpoint inhibitors, what would be the best treatment to give? There is no longer a debate regarding this. It has been shown very clearly that all being equal, patients are better off starting with immune checkpoint inhibitors. And you can see on the bottom right, the separation of the graphs. The black graph shows those who started out with immune checkpoint inhibitors, and then if they needed, went on to targeted therapy, as opposed to the patients in the red line who started out with targeted therapy, and then if needed, went on to immune checkpoint inhibitors. And you can see very clearly the difference in favor of starting with immune checkpoint inhibitors. So that's the rule. What are the exceptions? So the exceptions are certain patients who are not good candidates for immune checkpoint inhibitors because they have in their medical history conditions that increase their risk for side effects, or patients who require a very rapid response. The disease is very advanced, they're very ill, and we can't wait. Those are patients for whom we'll favor targeted therapy in first line. But if those aren't there, then we usually go for immune checkpoint inhibitors based on this data. So sort of summarizing the comparison of the immunotherapy drugs, and again, putting aside the targeted therapy. So really have three good options to offer in advanced melanoma today. We have PD-1 monotherapy, the Opdivo or the Keytruda, which are very good drugs, and many patients benefited long-term and were cured from these drugs. But it is the weakest of those drugs and is also associated with the least side effects and therefore the best quality of life. And we reserve that for patients who are very frail or who have a very high increased risk of side effects. And the other two combinations we mentioned, the Nivo-Rela, the Opdualag, which is intermediate in both efficacy and side effects, and the Opdivo and Yervoy, which is highly effective but also associated with higher potential for side effects. And the balance there depends on this triangle, which I show on the left, which is the fitness of the patient, the risk tolerance, both as far as how high we estimate the risk and also how high a risk the patient is willing to take when taking the drug, and the tumor burden, where very high tumor burden, brain metastasis, and other considerations would favor the more effective regimen, whereas low burden disease, less tolerance and so on might favor the Nivorella. And it's more rare today that we go for PD-1 immunotherapy, but it's definitely a legitimate option as well. So really, we have what we call an embarrassment of riches. They're really very good options in melanoma today, and I described them before, and we'll hear more about the targeted therapy. And all this is through really a cooperative work of scientists and clinical research personnel, the pharmaceutical companies, and most importantly, patients who participated in these clinical trials and really allowed these new medications to arrive and be available to all our patients today. Thank you.
What a wonderful talk. I appreciate all the time and effort there. As you can see, there's a lot going on, and absolutely I'll be stealing some of those slides as we talk forward. And now we come to the main event with Dr. Sullivan, who has been a part of this for over a decade now, I would say, and been really great. We task him every year with telling us what's coming up in targeted therapies, as we have somewhat exhausted, no pun intended, that immune activities, novel and newer T-cell therapeutics are available, newer BRAF and other targeted therapies are available. So Dr. Sullivan joins us from Mass General Hospital. Please go ahead. Thank you.
Thank you, Dr. Hamid. Thank you to AIM at Melanoma. It's a pleasure to be here. As Dr. Hamid says, I have been a part of this for many years, and it's been an absolute pleasure each and every year, although it's more pleasurable when I'm in LA at the Angeles Clinic. And if I was smart at figuring out how to transfer my photos from my phone to my computer, I would have actually shown the last time I was at Angeles, which was in 2024. So I've been tasked to talk about targeted therapy, and I've decided to call this When to Use Oncogene Targeted Therapy in Patients with Melanoma. So here are my initial disclosures. I have one additional disclosure, which is, as you've been hearing, we are living in an immunotherapy world, and I'm an immunotherapy girl. I'm not sure Madonna ever said that, but I think she did, at least when I think about talking about targeted therapy. As you've heard, immunotherapy has been the most exciting advance in terms of getting patients to where they and we want them, which is long-term disease control. But there is this entire pillar, as Dr. Cohen so nicely mentioned, called targeted therapy. And targeted therapy implies that there are targets. And so I figured I'd tell you a little bit about what they are. So on the left is a semi-complicated, but probably overly simplistic diagram about some of the signals that are involved in melanoma growth, in metastases and invasion, and even evasion of the immune system. In red are the genes that then become proteins that are mutated and drive cancer. You've heard about BRAF, and BRAF mutations happen in about 40 or 50% of patients with skin melanoma, and that's shown shaded in red on the right. RAS mutations, particularly NRAS mutations, are present in about a quarter of our patients. That's shaded in green on the right. And then KIT mutations are a type of mutation that occur less commonly in skin melanoma, more commonly in melanomas that arrive on the palms and soles of the feet, as well as in the nail beds. And then we see GNAQ and GNA11 mutations in the great majority of our patients that have uveal melanoma. There are also in gray, everything in red is called an oncogene, which basically means if that gene is abnormally turned on, that's associated with cancer. In gray are some genes that are commonly altered in melanoma that are called tumor suppressor genes, which means if you lose those, you're more likely to have cancer. And if you have an oncogene that's turned on and a tumor suppressor that's turned off, that's an even worse combination. So, and I should briefly mention that the only targeted therapy that's approved by the FDA are for patients with BRAF mutations, and these involve blocking RAF and MEK in combination, although you can block them individually as well. So Dr. Mehmi did a great job of taking us through adjuvant and neoadjuvant setting. I'd like to just return back to the adjuvant setting. This is a less elegant version of what he showed, but in yellow highlights are the treatments that have been approved in the last decade to treat patients after they've had surgical resection, but yet have high risk for recurrence in the stage 3 or stage 4 setting. And dabrafenib and trametinib is one such BRAF and MEK inhibitor combination that has been tested and approved in melanoma. And you saw this as well. This is called the COMBI-AD trial. This randomized patients with high-risk stage 3 melanoma to either receive the BRAF inhibitor dabrafenib and the MEK inhibitor trametinib, or to receive 2 matched placebos. And below are the final data for relapse-free survival difference. So you can see at the 8-year mark, there's a 15% difference in relapse rate for patients who received the drugs versus those who received placebo. On the right, in the lower section, is the proportion of patients who are free of distant metastases. And you can see an 11% difference at the final cutoff. And then what we care most about is, are patients more likely to be alive if they received the drugs versus receiving the placebos? And the answer is sort of. Certainly, if you were looking at a trial like this and a curve in the lower left, you would have rather been randomized to the treatment that the people that are on the black curve received than the green curve received. But statistics can be challenging, and this narrowly missed its final overall survival endpoint. However, as also Dr. Mehmi mentioned, it really mattered whether you had a BRAF mutation that was this so-called V600E mutation, which the great majority of patients with BRAF mutated disease have, versus a V600K mutation. And just to take you through this, the black curve represents the patients who are treated with dabrafenib trametinib. The green curve are patients who are treated with the double placebo. And what you can see is that a significant difference, both statistically and visually, in these two curves. And at the 8-year mark, an absolute difference of 8% and a relative difference of 25%, meaning if you received the combination BRAF MEK inhibitor, you actually had a 25% better chance of being alive at this 8-year time point. Conversely, patients who had a BRAF V600K mutation seemed to have an adverse advantage to receiving dabrafenib and trametinib, and that's characterized by the black curve versus the green curve. These are patients who just got the double placebo, and their 8-year survival difference is actually 13%. It's actually higher than in the converse, than the difference between patients who got BRAF and MEK that favored therapy. So it's a really interesting result, and it's not clear exactly where we're going to go, but when I do my summary slide on this, I'll tell you my opinion. What about stage 2 disease? So stage 2 B and C have comparable risk to stage 3A to stage 3C melanoma, so comparable risk. And there are 2 drugs approved in this setting, nivolumab and pembrolizumab. An additional attempt was to see if the BRAF MEK combination, encorafenib and binimetinib, were better than, again, double placebo. And with the emergence of pembrolizumab data and the nivolumab data, it limited enthusiasm, rightly so, to enrollment onto this trial. And so only about 1/8 of the planned enrollment occurred. and the trial closed to accrual. Now, to the credit of the folks who are running this study, they actually looked at the data, and the curve seemed to be a little bit better in the patients who received the combination of BRAF and MEK versus double placebo. There was no new toxicity signal, and so ultimately, it was a trial that will not lead to anything, certainly won't lead to the approval, but did essentially prove the point that BRAF MEK is probably better than getting placebo in stage 2 disease. And so to summarize adjuvant therapy, I would say that the follow-up data with the BRAF MEK combination to BRAF and tremelimumab shows ongoing improvement in the primary endpoint, relapse-free survival, and the secondary endpoint, distant metastasis-free survival, with a strong trend towards improvement in overall survival. And the signal is significantly strong, in my opinion, for the BRAF V600E patients. It's poor for the V600K patients. And in stage 2, there's an incomplete data set, which will not lead to regulatory approval of a BRAF targeted therapy anytime soon. And so despite what Dr. Mehmi may have said about only if there's a reason not to give immunotherapy in the stage 3 population, I would argue that BRAF targeted therapy in the adjuvant setting is a remarkably good choice for patients with resected stage 3 BRAF V600E melanoma, and a terrible idea based on that survival data for patients with resected stage 3 BRAF V600K melanoma. Okay, moving on to the advanced melanoma landscape. Dr. Cohen beautifully talked us through this. There are a number of treatment options. And I agree 100% with Dr. Cohen. This is the current frontline standard of care options for a patient newly diagnosed with BRAF mutant melanoma and BRAF wild type melanoma. And as he took you through that, those are the considerations we take in helping our patients make the best decision for themselves. Now, I want to take you back 10 years before the DREAMseq study, which Dr. Cohen walked you through, which compared the BRAF targeted therapy with the immunotherapy. And so 11 years ago, we would have debates at this meeting and many others about what should we start with. Should we start with BRAF targeted therapy? Should we start with anti-PD-1 based therapy? And we would present data that showed, if you look back at our patients that we gave BRAF targeted therapy to or anti-PD-1 based therapy to, we would often conclude that actually BRAF targeted therapy outcomes are worse after anti-PD-1, and so maybe you should consider BRAF targeted therapy in the right patient. And then we would look at the trials as they were beginning to read out, and we could say, well, here's the long-term data from the BRAF targeted therapy, which are on the left and encircled sort of in red, versus the frontline anti-PD-1 and anti-PD-1 CTLA-4, which are encircled sort of in the yellow. And we would say, it really does seem that this bottom line of this table suggests that immunotherapy is better. And so really it did take the DREAMseq. And so as was discussed, this was a really groundbreaking trial because it asked and answered a question that we thought we knew the answer to, but having known the answer now, it makes us very confident in what the right choice is for patients with newly diagnosed BRAF mutated melanoma that's advanced. And a simple trial, randomized patients to ipi-nivo, so anti-CTLA-4, anti-PD-1 versus dabrafenib and trametinib, and patients were allowed to cross over at progression. And you also saw this data, which essentially suggests that there's a strong difference initially, or at the 2-year mark, which was the landmark, that was the primary endpoint, are patients more likely to be alive 2 years after starting, and that curve continued to separate quite dramatically over time. But I think it's important to note that that was not true for every patient. And so the question is, can we learn about who these patients may be so that we can make a better recommendation for those patients? There's another study that was launched about the same time, and similar design, although not as large. Patients were randomized in arm A to start with encorafenib and binimetinib, another BRAF-MEK combination, or ipi-nivo, or to start with BRAF-MEK and then after 8 weeks switch to ipi-nivo, and then at time of recurrence they could go back to onco-bini, and that was called the sandwich arm. And to sort of orient you to below, which the colors aren't the same, but green and red are the patients who either started with ipi-nivo, that's the green curve, or that received the sandwich arm, which is the red curve. And what's clear is that the patients who either got were randomized to the green or the red curve did better than the patients who started off with BRAF-MEK and then continued treatment until they progressed. And this is the progression-free survival. This is the overall survival, and each are better for patients who had early ipi-nivo. And so the DREAMseq confirmed our bias that frontline immune checkpoint inhibition is better. It strengthened the data of ipi-nivo as the optimal frontline immune therapy combination for patients with stage 4 BRAF mutant melanoma, and notably a subset of patients had worse outcomes if they started with ipi-nivo, and all of this data was bolstered by the SECOMBAT trial. So are there any scenarios where we may start with BRAF targeted therapy in BRAF mutant melanoma patients? So when Dr. Atkins and team analyzed who these people were, which essentially were who were the patients that were more likely to die in that first 10 months who were randomized to ipi-nivo versus those who were randomized to dabrafenib and trametinib, what they showed is that the patients who did poorest were patients who had a high LDH and were probably a little bit sicker from their disease. And so thus, this is a regimen, BRAF targeted therapy, that we would consider for those whose performance status, meaning how well they were feeling globally, was worse because of their disease, or if they had an elevated LDH, which has long been known as a poor prognostic sign. There was also some data from the SECOMBAT trial that suggested that there were a few subsets based on various alterations in the tumor or a signal of inflammation. And ultimately, what they identified was that patients who had a low signal of inflammation seemed to benefit the best from that sandwich approach, meaning they got BRAF-MEK early, shut down some of the badness that was happening with their tumor, and then could go on to the immunotherapy and do well. These were a few cases of some of my patients. This is a 73-year-old woman who presented with severe anemia, and when we started working her up, she also had a large brain metastasis. This is certainly a patient that we would consider upfront BRAF targeted therapy, and she definitely had a BRAF V600E mutation. However, we were able to remove this tumor and this big tumor before starting immunotherapy, and she ended up having an amazing outcome with ipi-nivo. So in this patient, we cleverly avoided BRAF targeted therapy to date. Here are a couple of other patients that we couldn't. This was a 68-year-old who's had a bunch of tumors in the brain, but you really can't appreciate. But this patient was on a lot of steroids. We just couldn't get him off steroids, which even though if you start steroids after beginning immunotherapy, it probably doesn't blunt the immune response that much. But starting immunotherapy when patients are on a lot of steroids typically blunts the immune response, and you don't get as good outcomes. And so this patient started BRAF-MEK. This is another patient who had very rapidly progressing disease in the lungs, and we started this person on BRAF-MEK to slow down that disease. So we had no choice but to start with BRAF targeted therapy. And to summarize, ultimately, I would focus you on this last bullet, which is essentially patients with rapidly progressing symptomatic disease or requiring steroids that we can't get them off. Those are likely the best patients for an early BRAF-MEK inhibitor therapy. But based on that other study, the SECOMBAT trial, I would say we should do that for an abbreviated period of time before the disease is clearly progressing and switch those patients to immunotherapy. We have 3 regimens. So how do we choose amongst these regimens for our patients? Well, there are a few differences in these regimens. One is the number of pills per day, and obviously patients really care about how many pills a day they take, and so do we. And the dabrafenib trametinib regimen is only 5 pills a day, but there are some challenges with dose reductions. It's hard to to reduce this trametinib dosing without another prescription. And there's inflexibility regarding meals. You need to have 2 hours before, 1 hour before food and 2 hours after food. So there's a 3-hour window twice a day that you can't eat. Vemcobi, a lot of pills, some flexibility, but inflexibility also without meals. And oncorafenib and binimetinib is 12 pills a day, lots of flexibility with changing it, and lots of flexibility with meals. When we look at the side effect profile, basically dabrafenib trametinib causes fever in a great number of patients and way more than Vemcobi or Oncobini. Photosensitivity, which is essentially how sensitive your skin is to the sun, is much more common with Vemcobi than dabrafenib and trametinib or Oncobini. Liver irritation is more common with Oncobini. Nausea, vomiting is more common with Vemcobi. And so we really begin to think about what are the side effects. It doesn't appear there's any great difference in how well these three regimens work. And so ultimately, we have three reasonably well-tolerated effective therapies. They have different properties. Onco, Vem, and binimetinib have relatively short half-lives. Cobi, Dabtram, and trametinib have longer half-lives. That's important. If you stop the drug for side effects, it takes longer for those to go away. And the dominant toxicities may help in patient selection. Certainly somebody who's living in a very sunny place should probably not get Vemcobi because of the photosensitivity, as one example. So which regimen? It depends, but by and large, for metastatic patients, we recommend oncorafenib and binimetinib. And for the adjuvant setting, the only regimen approved is dabrafenib trametinib. In my final couple minutes, I just wanted to show that there are a few other targets that are being studied, but there are no approvals yet. GNAQ, GNA11 inhibitors are being used in something called an antibody drug conjugate for patients with uveal melanoma. PKC inhibitors, either alone or in combination with MET inhibitors, are being used in uveal melanoma. KIT inhibitors have been studied for a long time in acral and mucosal melanomas. RAS inhibitors, the first RAS inhibitor is actually in the clinic now. It just opened, and we're pretty excited about that. And hopefully in a later year, I can tell you more about that. But we've tried a lot of these inhibitors. Unfortunately, the great majority of patients don't have long-term benefit from these agents. And this is some data from the NEMO study, which compared binimetinib versus chemo in patients with NRAS mutations. And this is a table that summarizes data from 4 trials in patients with KIT inhibitors, was showing some benefit if you select the right drug for the right mutation. And so actually, where we're using these more and more are when patients as Dr. Smithy was saying, are getting TIL therapy. Several patients that we treat will have the tumor resection, but it takes 6 or 7 weeks for that product to be ready. But their disease is not going to wait for that TIL product to be infused to keep growing. And so sometimes, even though these agents like KIT inhibitors or MEK inhibitors for NRAS mutant patients or other inhibitors for other potential targets, they're not going to lead to long-term benefit, but they may serve as a bridge so that we can get patients to their TIL therapy and then stop them when they get admitted for their lymphodepleting chemotherapy and their TIL infusion and IL-2. And very commonly, if patients are going to do well, they'll do just as well when they get to TIL if they've been on these bridging therapies. In fact, they may even do better because, as Dr. Smithy said, you actually do see better outcomes in patients with lower burden of disease. And so even though these may not lead to low burden of disease for months and months, for that short window of time, they can be extremely effective. And so when to use? Well, strong evidence supports the use in the adjuvant setting with BRAF/MEK inhibition for V600E mutant melanoma. A few scenarios justify the BRAF therapy for advanced melanoma, and we're often using that sandwich approach for patients. There's no other approved oncogene-targeted therapy for other oncogene-driven subsets of melanoma, but we often are now using these off-label in that bridging window between TIL harvest and TIL treatment. And then, of course, we're commonly using these drugs in clinical trials. And with that, I will thank you for your attention and look forward to later in the discussion.
All right, in the interest of time, we will reintroduce Dr. Mehmi to speak to us about uveal melanoma and everything that is happening there. Lots of major findings and discovery.
Did I jump out? Oh, I did get out. I have to log back in.
You all right?
I kicked me out.
No. Well, as he brings up the slides, I will take some time to say that it's been a great discussion. We'll look forward to your questions. Don't worry about time. I think the last speaker is crummy and we'll go quickly through his slides.
Give me a couple of minutes. I'm rehiring.
All right, how about I do mine before yours? Uh-oh.
Am I?
No?
Yeah. Oh, okay, got it. All right. Okay, I'm on.
You're on. Okay, he's on.
Okay, sorry about that technical difficulty. So I've been tasked again to talk about some of the less commonly faced melanomas. And those are your uveal melanoma or ocular melanoma, mucosal melanoma, and acral melanoma, and we'll define those, what those are. I wanted to talk about some background in all these three different spaces and what's the current state of care and where we're going with the future. I have a lot of slides. Since these are some of the most rare melanomas, the standard of care therapies are not as readily found, but there's a lot of research going on, so we'll talk about that. And when we're talking about the uveal melanoma, we're looking at the inside of the eye, a number of different layers where the melanoma can develop, and that could be the choroid layer or ciliary body or iris melanoma. When we're talking about the mucosal melanoma, it's essentially the inside lining from mouth to anus that could potentially develop, and acral melanoma is nail bed or palms or soles of the feet, either weight-bearing or non-weight-bearing areas that could have melanoma develop and cause issues. We'll start off with uveal melanoma. It's not very common, only about 2,000 cases per year in the US and about 8,000 globally. Not particularly well-known risk factors other than having a nevus or melanocytosis or some gene mutations that are inherited throughout the family. The challenge with uveal melanoma is the early stage, even though curable, about 50% of those patients will go on to develop metastatic disease. That has been a very challenging scenario to deal with, but ongoing research has produced therapeutic options for these patients. With ongoing research and previously done research looking at the tumor genomics, we are able to define some of these patients who are at high risk of recurrences or developing metastases, and that's typically done through gene expression profiling, doing a biopsy of the small, tiny lesion in the eye, and risk stratifying it to either class 1A through class 2B. And that allows us to predict who are some of these patients who are going to have recurrences, and so we can monitor them closely with MRIs and CTs, so we can, when they recur, we can treat them. To date, there are no adjuvant therapies that we talked about for uveal melanoma. We did talk about a number of adjuvant therapies in cutaneous melanoma. I appreciate Dr. Sullivan's real-time debate answer on that. But there are a number of trials that are actually initiating that look to answer that question. And we talk greatly about neoadjuvant approaches in cutaneous melanoma, and that is starting to come up in uveal melanoma as well with different goals, though this trial is at very earlier phase in its early lifespan, and we'll look to see more data on this. There are a number of additional new approaches with virus-like particles trying to treat the initial primary tumor in the eye. Again, very early on, we'll continue to look for additional data here. There have been a number of adjuvant studies in uveal melanoma after patients have received their plaque therapy or proton therapy or enucleation of the primary disease, subsequently treated with a number of different options, but none have produced the results that are reliable and durable. So for that reason, a lot of these adjuvant options haven't become mainstream. The only therapy I'd say that has significant noise making ability in the recent years is ipilimumab and nivolumab in combination for high-risk uveal melanoma that was presented at ASCO a few years back, showed 70% metastatic disease-free survival versus a historical control. And this trial is actually getting ready for a larger phase 3 soon, start up soon, and we look to open that study here at the Angeles Clinic. Additional adjuvant therapy options are the cozinostat for high-risk uveal melanoma that is currently on hold but should be reopening for high-risk uveal melanoma, and as well as tebentafusp, which is already approved for advanced unresectable metastatic uveal melanoma, and we'll talk more about that. So once patients recurred, what are some of the options? Typically, it's very a patient-based approach depending on the disease burden, liver involvement or not, or in addition to liver, other sites of disease that will lead to us using either liver-directed therapy or systemic therapy. And these liver-directed therapy of various types, from immunoembolizations to chemoembolizations to radiation beads, perfusion therapy to the liver, are all different options, and we select them with our patients, their performance status, their disease burden, their comorbidities in mind prior to embarking on any of these therapies. PHP is one of the options that's been well studied and actually FDA approved in metastatic uveal melanoma, showed that when you perfuse the liver with high dose melphalan, you're able to control the disease, improve overall survival. This is a reasonable option for patients who have liver limited disease and fairly difficult to tolerate therapy. Given every about 6 weeks. Following each treatment, I've seen that the patients are actually, have low cell counts, fatigue, appetite changes for about 2 weeks prior to improving in those situations. Similarly, another trial for isolated hepatic perfusion, similar outcomes. In terms of liver lesion-directed therapy, there are a number of different options available, but I wanted to highlight Jefferson University's experience with immunoembolizations. They looked at a large number of patients who had gone through this therapy and compared them to some of the other options available, and showed it's a single center trial, so I would recommend taking it with a grain of salt that immunoembolization is a reasonable option for these patients and can produce reasonable results for some of these situations. this was a small trial with PERIO-01. It's a delivery of an SD101 with combining with immune checkpoint blockade. SD101 is a small oligonucleotide that is a TLR9 agonist, sort of creates an inflammatory environment in the tumor area. And when given with immune checkpoint blockade, for example, either pembrolizumab and nivolumab, it led to very good disease control. And we are still waiting to see where this trial goes in the future, currently in development. Dr. Sullivan did an amazing job talking about some of the target therapy options in cutaneous melanoma. Similarly, we are looking at some of the target therapies in uveal melanoma, and particularly GNA11, GNAQ pathway. And based on that, one of the most interesting options that have come up is IDEAYA's darovasertib and crizotinib option that's actually gone through phase 3 trials, and the data is going to be presented at ASCO in about a couple of weeks. The phase 2 data showed that, you know, there's a very good objective response rates with this option, though the challenge with this option has been the toxicity and ability of the patients to continue therapy or the combination therapy. And typically, crizotinib has been the culprit with adverse events and leading to its discontinuation. Overall response rates about 30% in these patients with any line therapy, meaning prior therapy, exposed patients, and but better responses in first line setting where the patients haven't received any prior therapy. Typical adverse events through this option tend to be more gut related or blood pressure issues, and but there are a number of different strategies that could be applied to improve those adverse events. The other clinical trial I wanted to highlight is the DYP688, an antibody drug conjugate that delivers a GNA11 GNAQ inhibitor to the, so it's a targeted delivery of a targeted agent that seems very interesting and potentially leading to improvement in inhibition or inhibition of the GNA11 GNAQ pathway and leading to improvement in disease control and also less off-target effect of the drug, leading to less side effects. We also have seen the role of ipilimumab, nivolumab, though very limited in metastatic uveal melanoma, but it's an option that we do use for select patients in the absence of any clinical trial options or patients who are HLA-A*02:01 negative, which I'll talk about subsequently. Ipi-nivo can also be combined with PHP or hepatic perfusion shown by Chopin trial. Again, small numbers. It was updated back this past year in ESMO, showed very good disease control rate at 1 year in the combination arm. The limitation of this trial is that the benefit was assessed only in hepatic disease control and not in the extrahepatic. So we look to see some additional data for this option to be widely applicable. So the only FDA-approved systemic therapy for uveal melanoma is tebentafusp. I show you the initial data here that showed that when you look at HLA-restricted patients and randomized 2-to-1, control arm were treated with either pembrolizumab, ipilimumab, or chemotherapy, and the primary endpoint of being overall survival. This trial met its primary endpoint, showing that the tebentafusp treatment led to 21.7-month median overall survival versus 16 months with control arm, and for that benefit, this drug was approved. This drug actually was presented again at AACR in San Diego a couple of months back, showed 5-year survival benefit in some of those patients where the control arm 5-year survival was only 8%, and the tebentafusp arm treated had 16% 5-year survival. And moving the BiTEs forward, Dr. Hamid had presented this data a while back in ESMO with PRAME targeting bispecific in uveal melanoma and other solid malignancies. Of these, I believe 4 patients treated were uveal melanoma that had durable responses, partial responses, and we look to development of this drug in combination with either tebentafusp or others in uveal melanoma space. RP2 with nivolumab is an ongoing trial versus ipilimumab plus nivolumab, where RP2 is injected into the tumor while the nivolumab is given via IV. Initial data looks very good with disease control rate without any complete responses. Overall therapies are well tolerated. Again, like I said, this trial is a bit slow in its accrual, but ongoing, and we look to see additional data on it. PI3 kinase inhibition is also a developing story in uveal melanoma. Rigonislimab is one of the drugs being developed, presented last year as a trial in progress at ASCO, and we look to see additional data when I hope it's at this conference, it's not in the future. As you heard from Dr. Fischer and Dr. Smithy about TIL therapy in cutaneous melanoma, this is also an active field in uveal melanoma. The data from UPMC, University of Pittsburgh Medical Center, looks very promising, and they'll be updating that data this year at ASCO. Though this particular option is not as well utilized in uveal melanoma, but I believe IMA 203 drug will change that due to its response rates and durable disease control, even in patients who have been previously treated with tebentafusp. Now I'll quickly move to mucosal melanoma and acral melanoma together. These are sort of the relatives of, I wouldn't say relatives, actually, the other counterparts in melanoma. Mucosal melanoma, like I said, is one of the entities, and it could be presented from mouth to anus, or rectal region or genital region, and all of these regions carry a different sort of genetic makeup of melanoma, leading to a very wide variety of outcomes to our current available treatments. When you're looking at mucosal melanoma, as we talked about the different options that are available in adjuvant setting for cutaneous melanoma, similar isn't true for mucosal melanoma. The outcomes aren't the same, even though those patients have been studied in this setting. The Chinese group looked at chemotherapy and temozolomide plus cisplatin, comparing to the high-dose interleukin-2 and some of the other interferon alpha regimens, seeing if adjuvant options could be viable treatment options in this space, and showed that chemotherapy with cisplatin and temozolomide are actually reasonable option, though the toxicity risk is significant, because they do improve median relapse-free survival, slight improvement in median overall survival when you use these options. At least in phase 2 and phase 3, the overall survival data is a bit limited. There are ongoing adjuvant studies in mucosal melanoma listed here. In metastatic setting, the role of immunotherapy is reasonable at best. At the moment, we're not quite sure if ipi-nivo versus Opdualag or single agent PD-1 are reasonable, but the strongest data does exist for ipilimumab and nivolumab, showing overall response rate 43% with complete responses at 14%, overall survival at 26% from Checkmate 067 study. Similarly, Opdualag from Relativity 047 showed a benefit in mucosal melanoma, and those are some of the reasonable options in this space. We typically combine anti-angiogenic drugs, Avastin or similar, or other orally available anti-angiogenic drugs with PD-1 for a number of different translational reasons that allow improved response and outcomes. Here are the 3 different trials that I've highlighted showing long-term durable responses with these combinations in first-line setting. The strongest story for TIL is in mucosal melanoma of any therapies, looking at 12 patients with a median follow-up 35.7 months, showing an objective response of 50% with the duration of response median has not reached. So this actually is a very good option for very select patients, and at the same time, this is in 12 patients, and we look to see additional data in a larger cohort. Number of different research clinical trials are ongoing here in the US and ex-US to improve the outcomes in mucosal melanoma. Similarly, in acral melanoma, most of our therapy is guided by what we do in cutaneous melanoma, such as Ipi-Nivo, or Nivorella, Opdualag, or single-agent PD-1, but some of the retrospective data hasn't borne that out that one is better than the other. As we combined anti-angiogenic drugs in mucosal melanoma, similar efforts have been made to see if the PD-1 outcomes could be improved with combining it with anti-angiogenic drugs. And the response rates are reasonable and rarely will use in select few patients. Due to time, I will fast forward to my conclusions. So all 3 entities are rare with little known risk factors. Adjuvant therapy options are they require additional trials, and systemic therapies does have some options, and though the list isn't the same as cutaneous melanoma, but through clinical trial participation, we look to increase these options for our patients.
Okay, thank you. Thank you so much. I'm back again. Let's see if I can share my slides. And we'll go quickly through here. All right, so I was tasked today to talk about novel therapeutics in melanoma, but it's just the point, as what you've seen here, that as patients and physicians, we should be able to think about other options that come through even in the first line, second line, and further. I'm going to go quickly to show you some of what we have seen in the clinic and what's available, to point out that there will always be something that we can offer you. Here's what we know today, that we can help most patients, about a third to long-term survival, but there are a subset that have primary or secondary resistance, and how can we identify them and move forward? Well, the thing that began it all was anti-CTLA-4 therapy, and some of the trials we're doing now are looking to escalate doses. We've known this. The top left is the data with higher doses of 10 milligrams of ipilimumab with better long-term survival. So newer drugs that conditionally activate in the tumor microenvironment are helpful, and we can shown that we can get them to higher doses moving forward. What about the tumor microenvironment? We've learned, and this is stuff from Swag and Katie Campbell, that there are ways of understanding who will respond and who won't. This is looking through one tissue slide and understanding the plasma CD4 T cells. This is coming forward, some predictive markers that we need. We've also found out that leading to tumor resistance or exhaustion, or even the loss of response, is Tregs. Those are bad T cells that regulate the good T cells and render them inactivated, as you can see in the upper area here. Clinical trials looking at drugs that target Tregs through AKT. This is an oral Treg inhibitor are there, and this is for patients who have failed PD-1 therapy. Oncolytics, you know from TVEC and some of the Replimune data, but that's RP1. You can see here the platform going forward, RP2 and RP3, can place multiple different immune targets inside that vector. And when we do that, you can get more directly into the tumor. And when you put it in a viral vector, if you have toxicity, you can turn it off by just giving an antiviral. Here are the results of these oncolytics in patients who really cannot get systemic immunotherapy, solid organ and transplant patients that show good responses, as you can see on the bottom here, durable responses. So we will develop those. You've heard about the T cells and maybe the B cells, but the NK cells have been the triplet that's not gotten as much attention until now. This is data that Dr. Mehmi just presented of a drug that we've been using that we like to call a NK cell immune checkpoint inhibitor. And this is a checkpoint that works for dendritic cells and NK cells. Some of the data we've seen here is what you want to see here is response to primary resistant anti-PD-1 therapy. And this is data that we're taking forward and looking at this drug in combination with PD-1. Here, you need a picture to prove it to you. These are patients, this is a patient who's had significant immunotherapy and targeted therapy before. And you can see proof in the tissue that you can see increased NK cells and even increased T cells and antigen presenting cells here. What's most interesting for me is that this is a target that is expressed on patients who have low PD-L1. And what do we know from that? Those are patients, melanoma patients, that respond poorly to immune checkpoint inhibitors. But what else do we know? The majority of other solid tumors are low PD-L1 expressors. And if we have low response with immune checkpoints, including PD-1, CTLA-4, and those solid tumors, maybe it's a better way to look at this type of targeting in combination or in single agent. And here's the proof. This staining in hepatocellular non-small cell lung cancer. So these discussions we have in melanoma are not just based on our community here. The data that we've done, the trials that we run, set the stage for development and breakthroughs in other solid tumors. Here is another off-the-shelf NK cell that looks like it works. You don't need to be a radiologist to see that this stuff is bad and this stuff is good, and then that this tumor is shrinking. Here are this is tumors that really don't respond. Desmoplastic sarcoma and lung cancers and chondrosarcomas. So a lot of future here in these drugs. Antibody drug conjugates started in other solid tumors. So I just conflicted with what I said, but we've been doing ADC trials in melanoma for 20 years. I think that's how Dr. Sullivan and I met at one of these trials. And what is it? It's an antibody that targets a protein on a tumor and just carries chemotherapy with it. So it drops off the chemo into the drug. You heard about this drug from Dr. Mehmi. This is an ADC that targets GP100 that's present in a whole bunch of ocular melanoma. But if you look down here in these gray squares down here, that gray square is non-uveal melanoma. So there is a response, and we look forward to the presentation of how this did in other solid tumors. There are multiple solid tumors that are trials that with ADCs that are taking melanoma. Here's one of them. This is an antibody drug conjugate that targets B7H3. That's an immune marker on our solid tumors, and this looks very good. We have some melanoma patients in it. You can see here cervical cancer, liver cancer, head and neck, and melanoma, and the melanoma cohort here. And we know that getting chemo to melanoma can be helpful. We've had previous trials of immunotherapy plus chemo. That's biochemo. That's 25 years ago we knew that. PD-1 and VEGF together have seemed like a good idea, except there has been toxicity until we have these new bispecific antibodies that you can see here. There's an anti-VEGF portion and there's an anti-PD-1 portion. How is this better? Because it goes and only works where the tumor is expressing PD-1 or PD-L1. How is this better? Well, There are 4 major drug companies that are developing this platform, and if we're to move forward in immunotherapy, this is the drug to do that. We've seen that it has less treatment-related adverse events, and this is what this shows. You don't have to learn it, but trust me. There's encouraging efficacy in different indications. Here's a response rate in heavily pretreated melanoma patients, albeit 22 patients only, 1 complete response, 5 partial responses, and stable disease is 7. So you add that up, that's 13. That's over half the percentage of patients had disease control. How about immune suppression? This is a clinical trial drug that targets the glucocorticoid receptor. You know steroids are bad. You heard it 3 or 4 times during this talk, and this blocks that glucocorticoid receptor, and this is a trial we're looking at to move forward. The mechanism of action is not that tough, but you can see here this pathway works in many different areas of the immune system. There are other targets. HPK1 is an immune suppressor that affects both T and B cell signaling. And these are oral pills that are coming forward in multiple trials. This is not the first one, but this is one that'll be opening shortly at our place. What about T cell therapy? Well, you heard a lot about this one, Imantic, so I don't need to go over it again. But what I can say here is these are patients that are this targets PRAME. These are patients that have seen immunotherapy before. These are uveals that are hard to treat. But you can't always treat with a therapy that requires leukapheresis, lymphodepletion. That's high-dose chemotherapy. That means you get 1 shot at high-dose chemotherapy. Is this Imantic? Is it TIL? Is it the Obsidian drug? Well, there are other things to look at. This is the aforementioned IMTAC that targets PRAME and brings CD3 close. This is based on similar to a tebentafusp backbone. But you can see here on the top right, working in multiple solid tumors. Why? Because this target is expressed in a multitude of other tumors. There's combinations with other IMTACs like tebentafusp with PD-1, etc. And you can see here now we're understanding who responds to it. If you're PRAME positive, you do better in survival. It's not about response, it's about long-term durable survival. We're looking now at circulating tumor DNA. Who does well? The ones where the circulating tumor DNA comes down. How do we know? Not imaging, but just blood tests can help. But you take all of this together, you come into this idea that, hey, if I can take T cells somewhere, how about I use something to take NK cells somewhere for lymphoid, and this is data from MD Anderson looking at NK cells that are targeted, armorized to go to certain targets in the tumor. And we're looking at that, not us here, but this is David Hong, who does something like what me, Dr. Cohen, Dr. Sullivan, Dr. Mehmi do, but this at MD Anderson. And we're looking at this in other solid tumors. And in fact, Dr. Bellaglitza is looking at this intrathecally, that is into the brain, to take care of brain mets and leptomeningeal disease. There are new CAR agents that target other targets if you're not HLA-A2 positive, if you don't express PRAME. And we're looking at how to decrease toxicity, and these are trials that have accrued, and you'll see data coming forward. Using an interleukin-6 receptor blocker, that, as you can remember, if you're in COVID, decreased all of the inflammation. We think it can decrease inflammation. High levels of interleukin-6 are associated with poor response to immunotherapy. So you'll see some of that. And as we've gone forward, we've realized that interleukin-6 has some interplay with higher VEGF levels. And so you can see how these VEGF targeted drugs can also work there. As we go forward, you get good outcomes. To come to an end is to say that, 25 years ago, there was one option, and 20 years ago, 2 options. And then when we began this, maybe 3 or 4 things to talk about. But the list of options now is never ending. And as long as the patient can take therapy and is willing, there is a lot out there and there's a lot of hope. So I will stop sharing there. And thank you, and get into questions. So when everyone comes back to join us, we'll go to about 15 minutes of questions and we will go forward. Dr. Sullivan, can you update us on the state of vaccines and melanoma therapy?
Sure. The history of vaccines and melanoma therapy is a long and sad history until recently. There were a number of exciting initial studies, a lot of this done at National Cancer Institute in the 90s and 2000s and then other institutions that really just showed that the approach wasn't working. And what's changed is I think we've gotten better at identifying antigens that really matter, which the immune system can hone into. And then I think we've gotten better at identifying antigens that are unique to individual patients. And so, as Dr. Mehmi showed, there's now an individualized vaccine approach that's been moved forward by Moderna in collaboration with Merck that's shown exciting data in patients who have high-risk disease. There's a large phase 3 trial that's been launched and hopefully we'll hear about sooner rather than later. And if that trial is positive, then I think the vaccine field will explode in a good way. And there are just a couple of other points. There's an interesting vaccine that isn't against personalized antigens, but actually against antigens that are either on the tumor and the tumor microenvironment, like PD-L1, IDO. And that data is actually looking very promising with an agent called mRNA 4359. I always get it confused with 4157, which is the neoantigen study. And showing activity in patients whose disease has progressed after PD-1 inhibitors in combination with pembrolizumab, and then also in the frontline setting in melanoma and non-small cell lung cancer. So I think the answer to that question is we're getting there and we're finally seeing real tangible results in clinical trials, particularly randomized trials. And I'm very hopeful that over the next 12 to 24 months, we'll see even more impressive data that will continue to invigorate the field and lead to more development and optimization.
Dr. Hamid, can you unmute yourself?
For Dr. Smithy, can you update us on the data with TIL in acral melanoma? What do you know? And
Yeah, so I think the exciting thing about
can you lend to
TIL
us
with
there?
both acral and mucosal is that it doesn't seem to be, less effective. I think we're used to telling our patients with checkpoint inhibitors we expect less of a response than our, high TMB UV exposed cutaneous melanomas. But both that subset analysis that Dr. Mehmi showed for the mucosal patients from the lifileucel trial, I think very promising. And then there's retrospective data from the NCI comparing all the patients they treated over the years with acral melanoma and then non-acral melanoma. And really the progression-free survival curves like overlay each other. So I tell patients that, it doesn't seem like you're at a disadvantage for a response for TIL if you have acral or, kind of more standard cutaneous melanoma.
Okay, thank you. This is one for Dr. Cohen. Can you give us some of your thoughts on how to monitor for toxicities and mostly the cardiac toxicities? And what would you do differently in a PDL positive or negative patient for therapy?
Right. So regarding toxicity, I think we have to have a high level of suspicion without being hysterical. So sort of the balance between the two. We tend to take a very broad panel of blood tests for routine surveillance. Just as I mentioned before, we want to pick up the toxicity before it's clinically evident, so before the patient is feeling bad. And we often do that with troponin or CPK, so we can identify the cardiac enzymes increasing when the patient is completely asymptomatic. and then do the workup. So I think that's something that could be done. So in general, we have to have a high level of suspicion and do a workup. Of course, when with any symptom that's presenting, there could be a wide variety of other reasons explaining it, whether it's a tumor itself, infections, or other things. So we have to rule it out before we determine its actual toxicity. But we do have good treatments for it, so it's worth identifying. Regarding PD-L1 as a point of decision, it's not, at least where I come from, it's not standard practice to test PD-L1. I think in most places it's not standard, or it's not guideline to test PD-L1 as a decision maker. But if the data is available, we know that PD-L1 negative patients are less likely to respond, and that shifts us towards combination. We do have data, and that combination works better in those patients. I think that's a definite consideration.
Okay, thank you. As we come to the last type of hybrid question here, I'm going to go through and ask everyone what they think is the most interesting thing that they are looking forward to seeing in future meetings presented. And I will start with Dr. Sullivan.
So, I mean, I think what I alluded to, with your last question, I'm really excited to see the data from the randomized phase 3 trial of the V940 personalized cancer vaccine in the adjuvant setting for a couple of reasons. One, based on the randomized phase 2, which showed really exciting results, I think there's a decent chance that that'll be a positive trial. And if it is, it will be another example of melanoma leading the way in a new therapy for patients with cancer. And as somebody that worked on cancer vaccines in the late 1990s and early 2000s, it'll be an amazing achievement to see that type of an approach make it to the market. So that's I don't know when that's going to be reading out and when we'll see that, but hopefully sometime in the next year.
Okay, next, Dr. Cohen.
I think cell therapies are probably where we're going to see the added value. I think the checkpoints sort of are reaching sort of a ceiling. So I think some of the cell therapies, if it's the TCR-Ts or the engineered cells, might give us that extra several percent that we're lacking above the 50% sort of threshold that we've received with immune checkpoints. I'm looking forward to that.
Dr. Smithy.
I think just for some variety, also I'm looking forward to the darovasertib and crizotinib, results for uveal. I think that has a real potential to be a new standard of care for HLA negative patients.
Dr. Fischer.
Well, something we didn't talk a ton about today, although it was mentioned a few times briefly, is intralesional or oncolytic therapy. And I think as a surgeon or proceduralist, that's something that has always been intriguing to me, to be able to find, I think probably better select patients, as some of those trials have been mixed in their efficacy. And so new or novel intratumoral injections is something I'm looking forward to in the future.
And Dr. Mehmi.
You're muted.
I'll echo Dr. Smitty's comments that, I think crizotinib, darovasertib is going to be probably practice changing if the trial does show us the benefit that I think it will. In addition, I am excited about the Amedix 203 in uveal melanoma, its application, and especially for those HLA positive patients that haven't had the luck to respond for a long time or drive a significant benefit from tebentafusp. So I think there are some real game-changing therapies that are in development for uveal melanoma, and I'm excited for it.
Okay, with that, I wanted to thank everyone who joined us today. I'd like to thank my colleagues for spending time and educating all of us, including myself, and of course, AIM at Melanoma, and that whole group that has continued to fight, not just for education, but for patient rights. And we look forward to seeing you again same time next year. Thank you so much.